College, and there are other bodies as well, I think, who recommend individuals. What I've noticed, though, is there tends to be over time a kind of how can you put it? Maybe a concentration of people who are like-minded, and the like-mindedness tends to be an attitude that less is more, that somehow just when you find a cancer, a woman finds a cancer, treatment alone, even if the cancer is found at a relatively advanced point, is adequate. So there's kind of a mindset that has accumulated, and it's been concentrated within the membership of the task force, so that they tend to be like-minded on the subject and demonstrate a fairly clear bias against screening.
Thanks very much. And back to you on this, because when we're talking about that screening, we have heard, like many of you who have come to this committee, sharing with us that this should be lowered down to the age of 40. 40 to 49 should be included up to 74, and we may see that expanded as well. But going to you, looking at this issue, you're not part of the task force, but did you have a role to play when reviewing this information to provide your own recommendations? And from that, what type of information did you get back on for feedback?
Well, as I mentioned, I've been at odds scientifically with the various task forces since 2011, and I found that they've been very resistant to receiving information from experts like myself, like Dr. Kulkarni, Dr. Seeley, and others who are aware and very familiar with the scientific literature in the area. Instead, they've really focused narrowly on these old studies, which, because they're randomized trials, which is a great way of doing a study, but they're so old that they're not relevant. I think I may have drifted a bit from your question, so if you perhaps if you don't mind just repeating the last part of it, I want to make sure I answer you.
No, actually, you're answering that's where I wanted to go. I just wanted to know whether or not you had the opportunity to review some of these things. As you said, you have not been in agreement since 2011. So if we could just put it on the record, would you like to see these recommendations all reversed then that have come out from the task force?
Oh, absolutely. I agree with the other witnesses who have basically recommended strongly, based on the science, that women should have unfettered access to screening as of age 40. There should be strong consideration of continuing that screening beyond age 74, as long as women are otherwise in good health. And that's all backed by the modeling that I mentioned. There is at least the capability or the possibility of saving 1,000 additional lives in Canada every year if we did these things. Screening women in their 40s, extending screening beyond age 74, and also doing supplemental screening for women with dense breasts who basically for whom mammography is not going to work all that well.
Awesome. I want to switch over because I just have a quick question then for Dr. Kulkarni. Thank you so much for talking about this. I really liked your analogy comparing it to the airline screening. I always wonder if I've left that water bottle in there, so you get that anxiety, but the anxiety is sure a lot better than what else could happen. And I think that's what we have to see as for women. When they're talking about the harm being the anxiety, we can deal when we actually have solutions. And so I think by having this early detection, being able to have women go in there, that'd be really important. I want to ask you specifically because we are talking about the ages from 40 to 74, and I wanted to get your opinion on 75 and older and what that should look like. I have a mother-in-law who is phenomenally in great shape. I expect to have her around until she's about 120. So what do we do for those women over the age of 74, though, that are in just exceptional health?
We see that all the time. Like there are people who come for screening, and this is a very common comment that these people are healthier than me. So, as long as a woman is healthy, active, and has at least a 7+ year life expectancy, they should continue to screen. And that's what we are all recommending as part of, organizations. And those are the recommendations, that they should continue screening. And the program should allow these women to come into the screening program.
Wow, I still have time. Thanks so much. Oh, great. Okay, so So I'm going to go back to you then as well, because we talk about the screening and recognizing the dense breast, recognizing that makeup ethnicity may also have a change to the composure of one's breast. What do you think? I heard someone say about ages 25 to 40. What should we be doing for those women who are ages 25 to 40 prior to having an actual physical screening?
So at the current time, there is a lot of discussion about risk assessment. And so it's been generally recommended, even by the NCCN guidelines, that women who are between 25 to 30 years of age can get their basic risk assessment performed. They are not yet at the age where systematic screening is offered, but they should at least get their risk assessment performed, so that in case there's a flag that this person is actually high risk, then appropriate steps can be taken. High risk women generally get screened much earlier than the average risk women. So that's what we want to offer to all these young women.
Thank you, Dr.
May I add
Kearney?
something to that?
Very briefly, please.
We do have a program in at least one province, Ontario, for women who have been identified as being of high risk, and those women are eligible from age 30 to receive MRI and or ultrasound, which are more accurate for women at high risk.
Thank you both. Next, Dr. Hanley, please, for 6 minutes.
Thank you. Thank you very much to all the panelists. I also want to acknowledge the courage of my fellow panelists for speaking up. We don't often, I don't think we hear enough in general from people with lived experience, and to hear testimony from panel members themselves, I think is extremely powerful. Dr. Yaffe, I'll go back to you, but I'd appreciate brief answers with full respect, because I'd love to spend hours on this, but only have 3 minutes. I'm going to share some time with my colleague, Dr. Pawlowski. But randomized trials versus observational. What I'm taking away is really we can no longer do those randomized trials that were done in the 50s and 60s, because it wouldn't be unfeasible to carry to do a control and a test group, let alone the evolving technology. So. In other words, we can't really replicate those previous gold standard trials. So do you favor that what the U.S. Approach was to kind of understand the basic concepts and then move on and use only modern trials 2016 onward, even though most of them are observational? Could you quickly comment on the sort of the merit of that approach?
Absolutely. So randomized trials have proved the principle. But the technology used is no longer representative of current practice. Observational trials allow us to be more quantitative and use modern data to show what the possibility of mortality reduction is. And modeling will allow us to go beyond that and extrapolate from what we've learned in the randomized and observational studies.
Good segue, because I was going to ask you, based on the premise that all models are wrong, but some are more useful than others, could you defend your modeling practice? And I think you alluded to its compatibility with other modeling exercises, particularly in the U.S.
So it's not my model. It was developed by Statistics Canada in partnership with the Canadian Partnership Against Cancer. It's a wonderful model, and it actually is available for multiple cancers. It's been validated against empirical data, against actual measurements in the public. And we compare it to the U.S. models, of which there are 5. Actually, one of the models is from the Netherlands. So we always cross-compare against models, and they tend to agree with each other, which is great. And that gives us more confidence in their validity.
Thank you very much. Dr. Kulkarni, so many questions to you. I'm going to limit it to one. I believe the European recommendations are 45 onward.
That's correct.
Can you comment on that versus the U.S.? Has Europe, is there a difference in the methodology there or the basis for conclusions?
So different organizations tend to have a little bit of variation whether to start at 40 or 45, and we certainly see that even in some organization in the US, like the ACS recommends at 45. And I think we have some provinces here in Canada that also recommend 45 and above. So there's a little bit of variation. But overall, if you look at all the evidence that is currently available, it is best practice to start screening at 40. And that's what we are pushing for.
Thank you. I'm going to hand over to Dr. Pawlowski for the remainder. Thank you.
Dr. Yaffe, were you yourself an expert, subject matter expert advisor to the task force?
No, I wasn't. I was invited by the Ottawa Evidence Synthesis and Analysis Center to advise them. But as I mentioned, and Dr. Seeley mentioned, we both worked with them. There was interference by the task force on what that group was allowed to do.
Now, am I right that anyone who dealt with the task force had to sign a confidentiality agreement as part of working with the task force?
That's correct. And that's one of the reasons I wasn't willing to work with them directly, is I wanted to be able to speak freely.
To your knowledge, the people that work with them directly, did the task force follow the advice of its own experts? And we've already had Dr. Seeley saying, no, they didn't. But I know she can't talk for the other experts, and nor can you. But to your knowledge, did they follow the advice of their own experts?
I really don't know. I did speak with one of them who informed me that he felt that his interaction with them was minimal. He didn't understand much of the decision-making process, and really didn't feel that he had much influence on the process.
Is this troubling to you, that in a matter so important that people who are advisors are forced to sign a confidentiality agreement and therefore can't really make public what they told the task force?
Well, sometimes there are confidentiality agreements that are limited in time, and there's sometimes reasons for that. But I did feel that the restriction, especially when the whole process was one that I found very difficult to understand and agree with, I found that was very problematic. Why should we be looking at evidence, at studies that were done 60 years ago that are completely unrepresentative? That's just makes no sense at all.
Lastly, the allegation by those probably on the task force, and the reason probably they gave for putting non-subject matters as part of the task force making the decision, is that they didn't have any personal financial interest in the outcome. And I know some on taking the other side are going to say, well, of course, radiologists want to do more mammograms because financially they make a fair bit of money on mammograms. Do you want to just formally reply to that, either Dr. Yaffe or Dr. Kulkarni?
A brief
Well,
response,
I'll just
please.
say I'm a PhD. I get a salary for doing research, so the amount of screening that takes place really doesn't affect my personal life.
Thank you, Dr. Yaffe. Suite, Monsieur Thériault, pour 6 minutes, s'il vous plaît.
To be followed by Mr. Thériault for 6 minutes, please. Thank you very much, Chair. I would like to put my question to Mr. Yaffe. Jacques Simard, who is the Vice Rector of Research at the Faculty of Medicine at Laval University, suggests that without changing the age of screening for everyone, women should nevertheless receive personalized follow-ups based on their risk levels, taking into account, more specifically, breast density, their age, and family history. He suggests that those that have normal risk continue to undergo mammography every 2 years between the ages of 50 and 72 years, whereas those who had a higher risk begin annual screening in their 40s. And those that have high risk could also receive both ultrasound and MRIs on an annual basis. What do you think of that recommendation?
It's a very interesting recommendation, and I respect Dr. Simard's work very much, but I don't think at this point we have validation that it would work. In other words, in order to screen people less frequently, we have to really know that that the risk of developing cancer is so low that they're not going to have cancers missed because of that policy. And that has not at this point been validated. And most individuals don't express risk factors for breast cancer other than being female and getting older. So yes, a great idea. I think in the future this may be something we do, but we're not ready for that at the present time.
Merci.
Thank you. The chair of the Canadian Task Force on Preventive Healthcare stated during a press conference when the recommendations were updated and made public that it's not because there's more cancer that we need to carry out more screening. We need to ask, why are there more cancers in the population? So what do you think of that statement?
Was that for me or for Dr. Kulkarni?
For you, sir.
Thank you. I think that it is important for us to understand the causes of cancer and to continue to look for means for preventing cancer. We know that there are some issues around alcohol consumption. There are lifestyle issues, obesity, et cetera. But at the same time, I think prevention and early detection and treatment are not competing with each other. While we're learning how to prevent cancer, we should do what we can to prevent women from dying from breast cancer. And in fact, screening is often referred to as secondary prevention. We're preventing advanced disease. If we find it earlier, it's treated much more successfully. It's better for the patient. It's also better for the healthcare system because research that's about to be published shows that the costs go down as you do more screening because you have fewer advanced stage cancers that need to be treated.
Merci beaucoup.
Thank you very much.
Vous avez encore 2 minutes si vous voulez.
You have another 2 minutes if you wish to use them. Oh, all right. I will be very happy to continue. Yes, you have 6 minutes in total. A number of experts criticize the effects of false positives resulting from screening, and based on that, are unwilling to recommend systematic preventive measures for women in the 40 to 49 age group. What do you think of that? Could you tell us more about that?
Question, was that about, I thought I heard in French false positive. Is that what you're talking about?
Oui, oui.
Yes, indeed. Some experts, in fact, many of them, say that false positives are a very bad have a very bad effect, and therefore we shouldn't screen. Please, your response.
Yeah, first of all, I think we need to get away from the term false positive. It's completely a misnomer. False positive implies someone has said somebody has cancer when they don't. What the term really refers to is, as I think Dr. Kulkarni mentioned earlier, is that women are asked to come back for additional imaging to make sure there's no cancer. So the first screening exam is not absolutely clearly negative, so they want to make sure that they don't miss a cancer. Yes, if it takes a while before the answer to that additional imaging comes out, there will be some anxiety. Much of the research shows that anxiety is transient. And as Dr. Seeley mentioned, patients are generally much happier to accept that anxiety as opposed to the chances of a missed diagnosis of cancer and the need to treat advanced disease. So I think the task force is really off base in terms of considering that as a harm. It's something we should try to reduce the anxiety, not reduce the detection of the cancer.
Merci. Thank
you. According to the Canadian Task Force, the risk of false positives or abnormal recalls are really so high that the advantages pale in comparison. Overdiagnosing, too many biopsies as part of the potential harms. Do you think we have overdiagnosing in the studies that were used to come to these conclusions?
Again, if that's for me, I've actually co-authored with a medical oncologist, Dr. Kathleen Pritchard, who's one of Canada's outstanding medical oncologists in breast cancer, a paper called Overdiagnosis. And the point is that some cancers will grow slowly, and some people will, if they didn't know they had the cancer, that cancer may not have bothered them before they died of some other cause. But the reality is that the fraction of those cancers, and these are real cancers, but they're cancers that perhaps grow slowly, the fraction of those cancers is relatively small. It's certainly generally under 10% and perhaps in the order of 5%. The idea is to avoid over-treating those individuals. So once a cancer is diagnosed, try to determine if it's going to be one of the aggressive ones or the less aggressive ones, and make the therapy be suitable for the characteristics of the cancer. I think that's the right approach, rather than just not finding the cancer and playing Russian roulette with letting a dangerous cancer continue to grow.
Thank you, Dr.
If I may
Yaffe.
add there,
Very briefly, please.
I just want to echo Martin's sentiments that overdiagnosis is a word which is very difficult to understand. The role of screening is to find the cancer. How to treat the cancer is a different aspect of the cancer. And for us to determine which cancer is going to be biologically aggressive and grow and kill the woman versus which cancer is going to not grow and allow the woman to die of some other cause, this is something that we cannot tell just based on imaging. So it's not really overdiagnosis. We have to figure out which cancer needs treatment and which doesn't. That's not part of the screening process.
Okay. Thank you. Ms. Zarillo, please, for 6 minutes.
Thank you, and I really appreciate those comments by Dr. Kulkarni, because in modernized cancer treatments, there are so many more options, so I really appreciate that. It was a year ago, exactly, that Minister Duclos announced up to $500,000 in additional funding to the task force to help expedite the update of the breast cancer screening guideline. And he's quoted as saying, breast cancer screening guidelines that are based on the latest science is essential. Dr. Yaffe, I wonder if you think that this task force new guidelines are based on the latest science.
Well, I think that they would say that they have looked at the latest science, at least at some of the latest science, but because they've continued to focus so much on these 40 to 60-year-old studies, that raises concerns. The more modern data shows mortality reductions in the range of 40 to perhaps even as high as 60% for women who participate in screening, emphasis on the word participate, and also that the stage at which the cancer is found is earlier, meaning it can be treated more successfully and with better outcomes, less morbidity, and at lower cost. So I don't see that in anything that the task force has put in their literature. I've read their reports, and there's nothing that clarifies that they've really taken that more modern data seriously. And as mentioned earlier today, nothing on breast density, nothing on women who are who racialized, whose breast cancers tend to occur earlier. They tend to be more aggressive in some cases, and their outcomes we know are worse. They do much worse. So there's an inequity there.
Thank you, Doctor. And that inequity is something that I'm really concerned about, and I wanted to ask a question on that later, but I just wanted to follow up on this one. Dr. Yaffe, do you have any information on the parameters that the government gave this task force? Specifically, is there a cost-saving requirement? Is there an ROI that this task force had been asked to do in relation to women's health and breast cancer?
I don't know the answer to that question. I suspect that there is an underlying sentiment among task force members that spending less money on breast cancer screening will free up money to do things that they may be more interested in, but I don't know that for a fact.
Thank you.
But as I mentioned, what we've learned is there's actually a potential cost reduction associated with screening.
Thank you. And I'm going to ask Dr. Kulkarni the same question, just about, do you have any information on the parameters the government gave the task force and anything that might be related to
I
money?
don't think this information is available to any of us from the outside. So I don't have any information. But just to address another thing that was brought up is mammographies actually don't pay that well. So that this is a misconception that reading more mammograms is an easier job. For example, a mammography would pay 10 times less than what a CT scan would pay. So anything related to women's health is really not that well reimbursed. So you can say that there's another problem right there. It's not being prioritized.
Yeah,
but
and
no,
I appreciate that.
Information.
I appreciate that, because also to the work of women not compensated properly either in the medical industry. Dr. Kulkarni, I wanted to ask you about the what expertise do you believe needs to be included in the task force with a back to the drawing board recommendation that could come from this committee?
So basically, they had invited some advisors. We heard from 2 of them today in the evidence review. There are some other advisors that were working directly with the task force. So all of these people need to be talked with and find out if the decision that was made, the draft recommendations, is that a unanimous decision? Were there any people within the team that felt that this was not okay to do? So that's one thing. Second thing, as we saw, that these recommendations cannot go forward as they are. They need to be reversed, or they need to be at least temporarily stopped till the investigation is fully over. And people should be encouraged, physicians, all family physicians should be encouraged to follow provincial guidelines for the time being till this is resolved. Because rolling it out the way it is going to be detrimental to the country.
Thank you. With that, Mr. Chair, I would like to ask that this committee ask Public Health Canada and the government to supply to this committee the parameters that were given to the task force for their updated study. I also have another question, Dr. Kulkarni, just around, actually, Dr. Yaffe said it, but this debate with the doctor, that was certainly my experience as a dense breast woman. I had to have a debate with my doctor for 2 years, and I worry about non-white, as was mentioned earlier by Dr. Seeley, how much they would have to debate and fight with prejudice and bias. So I'm wondering if you wouldn't mind sharing how we can overcome that bias at the doctor's office.
So first of all, public education is very important. I think we are not spending enough dollars in actually informing people. We have a huge population now, which is very diverse, and we are not addressing that. And the most important thing is the guidelines. The guidelines have to endorse that we need to do this, and that is followed by capacity. The wait times in our country are horrendous right now. And that does not allow us to open up our doors to more and more ultrasound screening. So it's a huge capacity issue, and so there's a lot of work that needs to be done so that it can be equally available to everybody without them having to fight for it.
Now, I don't remember seeing that in the task force.
Okay. Ms. Zerillo, thank you, Dr. Kulkarni. That's your time. Ms. Goodridge, please, for 5 minutes.
Thank you, Mr. Chair, and thank you to the witnesses for being here. It's refreshing to hear common sense solutions being brought forward here. And as I've done so much research into this over the course of this brief study, there have been so many different organizations that have very quickly come out being opposed to these guidelines. Dr. Kulkarni, would you like to see the reversal of the task force guidelines? Would that be your recommendation?
Yes.
Thanks. I appreciate that. So it is, to me, apparent and obvious that there are very serious issues with the task force guidelines. This week we've heard evidence pile up from a variety of experts, and I think it's important as such. And so I'm going to look for unanimous consent to move the following motion. Given that the federally created Canadian Task Force on Preventative Health Care decided not to lower the breast cancer screening age guidelines, and that Breast Cancer Canada said that it was, and I quote, deeply concerned by the task force guidelines, the committee reports to the House that the decision by the Canadian Task Force on Preventative Health Care should be immediately reversed, and Breast Cancer Canada's screening should be extended to women in their 40s, as this will help save lives.
Unanimous consent is not required to present the motion because it touches on the subject matter at hand. So the motion is properly before the committee and is in order, and the debate is now on the motion. Dr. Hanley?
Okay. I thought I saw Dr. Ellis's hand first. I thought I saw Dr. Ellis's hand first.
I saw yours first.
Okay.
Sorry,
then
Mr. Chair, I was not. I asked for unanimous consent, and
You asked for unanimous consent to move the motion, and you didn't need it.
To pass the motion.
That's not what you said.
Sorry.
Okay, so you're looking for unanimous consent on the motion. Does Ms. Goodrich have unanimous consent to adopt the motion as presented? No. Okay. You do
So,
not have
Mr. Chair, let me get this straight. We've heard from countless.
No, you don't have unanimous consent. It appears that there's a willingness to debate the motion. Is it your intention to withdraw the motion, or are we going to have a debate on it? All right, Dr. Hanley, Dr. Ellis, Ms. Goodrich.
Yeah. So I accept the motion. I just don't feel comfortable with the recommendation, because I am not sure that although I do think that ultimately we need to get to a place where we have a uniform recommendation on screening. I'm not sure that we can direct an independent task force as to what to conclude. I think we have to find a way to advocate for guidelines and advocate for family physician education. So I think my interest is in getting to the same place. I'm not sure that this is the correct process to do so. Thank you.
Dr. Ellis?
Well, thanks very much, and certainly, I respect Dr. Hanley's comments on this. I think the difficulty is we've heard overwhelming evidence in this committee, and certainly it's piling up by the minute. We have, one of the world's foremost experts, Dr. Yaffe here, who has worked on this around the world for, as he said himself, 44 years. We know very, very clearly that the evidence would suggest that women should be offered screening for breast cancer between the ages of 40 and 79. That means that women would have access without having received mixed messages, that it would be an incredibly strong message from this committee to tell the task force that what they have concluded is incorrect. I realize that many of us sitting around this table may not be scientific experts, and certainly I realize we're not on the committee. The difficulty, as we have heard very clearly, though, is continuing to allow a task force to operate in a manner which is disrespectful of science and anti-screening, anti-prevention. I think that those are words that are not too strong. We've heard them repeatedly here. That continuing to allow a task force to operate in that manner is reckless, and especially when we have also heard that 1,000 women will die based on the reckless nature of Canada's preventive healthcare task force. And that is something that I realize perhaps many would argue that is not in the purview of this committee or of the federal government. However, I think that the important fact that we need to remember is that this committee can have an incredibly loud voice out there on behalf of Canadian women who will die in numbers that they shouldn't because of inaction or inability or perhaps ignorance of a committee that really does not want to consider the science. That is dynamic, that is changing, and for those of us, I was a family doctor for 26 years, and realizing that science does change is an important aspect of providing excellent quality health care. I think the other important thing is for the Canadian Task Force on Preventive Healthcare to come with a bias, as Dr. Yaffe had suggested, and other witnesses have suggested, to come with a bias against screening and prevention is a non-starter. It's illogical to think that a committee based on preventive health care would have a bias against screening. That is nonsensical. And then, of course, to not allow women to make well-informed decisions based on a discussion that they can have with their health care provider is incredibly misogynistic, in my opinion. Of course, as I said, clearly I'm a male, former health care provider, and to not allow women to have that opportunity to have that discussion is problematic for me. And to allow that to not exist is something that is going to result in the death of more women is absolutely intolerable. I will state for folks that this is an incredibly personal thing for me. My wife had breast cancer diagnosed at age 48, and thankfully she has made it past her 5-year mark and has made a fantastic recovery. So that being said, it is not just science, it's personal. And we look at the potential years of life lost for young women who are not able to access screening. And as our colleague from the NDP has mentioned, women from marginalized, racialized, often remote and rural communities not having this access. And you know what really struck me from our colleague from the NDP's testimony was the fact that she was a 48-year-old white woman who had to fight for herself. And I can only imagine, certainly from my perspective, what it would be like to be from a racialized community and having to attempt to advocate for yourself when the Canadian Task Force on Preventive Healthcare has said that you are not able at age 40 plus to access breast screening for breast cancer. I can't imagine how much of a daunting task that would be. In fact, I would suggest that it becomes an impossibility to advocate for yourself against a system in which the cards and the deck are already stacked against you. So perhaps, as my colleague Dr. Hanley suggests, that this isn't quite exactly the way it should be. But I think that if we do not come forward with an incredibly loud voice, as I suggested with the last panel, that the likelihood of the task force succumbing to anybody else, I mean, my goodness, if we have someone like Dr. Yaffe here suggesting that this needs to be changed, that the likelihood of the task force changing course and agreeing with him is probably slim to none, so that if we do not make incredible amounts of noise about this on behalf of Canadian women, then I think that we are doing it a disservice. I think the other things to really consider is when you look at the amount of press being played towards this, that it's incredibly important that the media understands the decision that is being made here and how important that is, that the task force is going against new evidence, that our neighbors to the south, the U.S. Preventive Task Force, has agreed that the evidence is there, perhaps, as Dr. Yaffe suggests, not to age 79, but certainly between 40 and 74, with the option for women over 74 to have screening based on, as Dr. Kilcarn said, based on their overall level of health. I think that makes perfect sense as well. But, for us to not make a loud noise about this when we have had the overwhelming amount of evidence to the contrary, I think that we are doing Canadian women a disservice. And I certainly don't want to be a part of doing Canadian women a disservice. And I would urge my colleagues, in spite of the fact that their belief is that this is not at the appropriate table to make this call, that they reverse their decision and they support my colleagues' motion put forward, asking for unanimous consent to support this motion. I think that science is against you. I think that public opinion is against you. And I think that history will stand against you and say that the decisions that you have chosen to make here are inappropriate. I want to be clear. I like my colleague, Dr. Hanley. I respect his decision. But that being said, if we do not make a loud noise about this, the difficulty that will persist is that we will continue to send mixed messages out there to provinces and to Canadian women, and Canadian women are going to die because of that. And that's not right. It's not right. It may not be exactly in our purview, but certainly it is within our purview to say that we categorically do not agree with the decisions that have been made, that their decisions should immediately be reversed, and breast cancer screening should be extended to women in their 40s. Honestly, I've asked other panels here today how best they think that we could make a loud noise with respect to that, because I believe that that is exactly what needs to happen. This needs to be a loud noise. It needs to be definitive. We need to call out a task force that is not respecting the science, that refuses to respect the science, that we know from other task force in the United States and Europe that they have chosen to not require randomized controlled trials because we believe that that part of the science has been settled, that we need to move forward and understand that we have new methods of diagnosis, new methods of treatment for breast cancer, and that those new and best methods need to be respectful of Canadian women. I don't think that I can state it any stronger than that, Chair, that I urge my colleagues to accept unanimously this motion put forward by my colleague from Fort McMurray Cold Lake on behalf of Canadian women who are dying senselessly because of the inaction and the ineptitude of the Canadian Task Force on Preventive Health Care. Thank you, Chair.
Thank you, Dr. Ellis. Ms. Goodrich?
Thank you, Mr. Chair. I would hope that we can just get to a quick vote on this and get back to the committee business. I think it is very troubling that members, particularly Dr. Hanley, who is a medical doctor, wouldn't vote in favor of this after all of the testimony we've heard here, but I'm really hoping that we can get to a quick vote on this.
Dr. Pawlowski?
Generally speaking, I'm in favor of this issue. However, and I've been involved with this a long time. Dr. Yaffe and I think spoke about this first a number of years ago. Don Davies, let me give a shout out to him with the NDP, also has been very involved with trying to get this issue addressed. I do have some concerns, as with Brendan, with a parliamentary panel of admitted non-experts trying to overturn the decision of a body, albeit seemingly flawed body, like the task force, and trying to overturn their decision. I think as much as possible, and certainly in my life, I separate the medical, because I still practice medicine, I separate the medical from the parliamentary, and I think that's important. We're not experts. I would suggest, and I'm just throwing this out because we haven't had time to fully consider the whole thing, but I wonder if there would be an appetite to amending the motion to read this. And again, I haven't cleared this even with my own party, but I'm suggesting there would be a more of an appetite to this wording. Given that the federally created task force on preventative health care decided not to lower the breast cancer screening age guidelines, and that Breast Cancer Canada said it was deeply concerned by the task force's guidelines, the committee reports to the House that the decision by the Canadian Task Force on Preventative Health Care should be immediately reconsidered and breast cancer screen and consideration be given to extending breast cancer screening to women in their 40s, period. I think that would perhaps strike a better balance between these two concerns about a parliamentary committee overturning or making an attempt to go where perhaps it shouldn't. But having said that, I think I agree. We've heard some compelling evidence on this, and certainly there's enough expertise here that suggests this decision ought to be reconsidered. I think this would be a better balance myself. So I don't know if I have to make that a formal motion to amend this, or if we need to pause for 5 minutes for parties to consider this.
Mr. Chair, I'll accept that.
Okay. So I think it would be best that you formally move the amendment. It appears that the Conservatives have already made up their minds on it, or at least one of them. So I'm going to take that as the motion being amended. And the amendment is to change the word reversed to reconsider, and after the word screening, to the wording will now be consideration should be given to extending extending to women in their 40s, as this will help save lives. So I think that's the essence of what you've suggested.
I think the wording at the end, and consideration be given to extending breast cancer screening to women in their 40s. I would probably, or if you want to save lives, as this will, in the committee's opinion, help save lives. I just don't want to, again, because there's an interpretation of the evidence that we're not experts in. So I would either drop the as this will help save lives, or in the opinion of the committee, this will help save lives.
Okay, the amendment is in order, so the debate is now on the amendment. I see Dr. Ellis. We did have a speaking order on the main motion, but the speaking order resets, so if you want back in, put your hand up. Dr. Ellis is next.
Well, thanks very much, Chair, and I thank Dr. Pawlowski for that. You know, certainly changing the wording is somewhat watered down, absolutely, but given that, I think that it's incredibly important that we move on this sooner than later, and I would hope that my colleagues would support the wording change. I know that here on this side we would be supportive of that. Because we can't move fast enough to make this happen. This has been a dilly-dally committee, not this committee, the task force committee has been a dilly-dally committee that has known this evidence for some time now. I don't think that suddenly in 2024 that this is a sudden thing. I think it's the inaction and the inability to hold the Canadian task force to task is what has allowed this to continue and has allowed thousands of Canadian women to die every year needlessly. So time is of the essence, folks. Let's show our colors and support this motion. Thanks.
Yes, Ms. Cirillo?
The written, the amendment, please, in writing.
Yeah.
Sean, can someone do that? I have to type on my little thing here. You're probably so much quicker than me. But.
Okay. It's going to require suspension in order to get the wording and get it translated. So I think what I'd like to do is to dismiss the witnesses and then tend to getting the amendment circulated. So
Sean, can the witnesses stay online if they're interested?
Absolutely. This is one of these you're welcome to stay, but you're free to go scenarios. So to each of our witnesses, thank you. So yes.
Oh, I'm sorry. Point of order. Before you suspend, I just wanted to have a chance to float the wording that I had, which is very similar to Marcus's, but I think before we get into a sort of a written.
That's not a point of order.
We would need to defeat his. We could do a sub-amendment, or we could defeat his amendment and then propose a new one. Those are your two options. So that's something that perhaps could be discussed on the suspension.
It's only that since it isn't in writing yet, and Marcus isn't sure of his own wording, I have a refinement to it.
Well,
I'm happy to do it as a sub-amendment. I want us to get to a place where we can all.
You and Dr. Pawlowski should talk. Okay, to our witnesses, we will not get back to you today. You are welcome to stay, but you are free to leave. We greatly appreciate you being here. You can see that you've sparked a spirited debate, and a debate that needs to be had. We thank you for your work, and we thank you for your presence. And as I indicated, you're free to go, but you're welcome to stay. We're going to suspend in order to get the amendment in both languages and in writing to the committee. The committee stands suspended.
Thank you so much.
Thank you.